Okay, good morning, good afternoon, good evening. This is DOW 2002 CPD Webinar series. Welcome to our very special guests, Dr. Masood Ansari from Australia and Dr. Ali Faisal Salim from Pakistan. Dr. Masood Ansari is a cosmetic surgeon and Dr. Ali Faisal Salim is a consultant in pediatric infectious diseases. We have two excellent presentations today. The first one is from Dr. Masood Ansari, and he's going to be speaking about cosmetic surgery. So over to you, Masood.
Assalamu alaikum, everyone, and thank you for giving me an opportunity to present this. I'm not going to go in details and elaborate too much about the cosmetic procedures or the cosmetic industry. The whole idea behind my presentation is to just give a rough idea what exactly happens in a cosmetic surgery world. And considering it's all get done in a private practice, I also run a very small private practice in Australia, Sydney. And just want to give you a bit of an overview in a very light way so everyone gets a bit of a grasp of what happened in those secret places behind the doors. Okay. So first of all, start with a disclaimer. I wasn't paid, unfortunately, by anyone. No organizers, no sponsors. I think we should get a sponsorship at some point. I need to buy a new bike, so that's where we need it. So the impression we have about ourselves is sometimes a bit different what actually the fact is. So if you look into the cosmetic practice, it's actually a combination of a cosmetic medicine and a cosmetic surgery. Even within the cosmetic medicine, so within a cosmetic medicine, you got quite a few procedures involved. Some are minimally invasive, some are non-invasive. So anti-wrinkle injection, that's the biggest non-invasive or minimally invasive cosmetic medicine procedure. More or less everyone has heard of Botox. Botox is actually a brand name. It is a botulinum toxin A. And there are quite a few other brands like Dysport and Xeomin. Actually, in fact, Dysport is getting very popular here in Australia, and that is a European brand. I guess it's a French company which is manufacturing in Ireland. So these are the commonest procedures get done. It's a multi-billion-dollar industry. And the funny fact about it that when US was in recession and people didn't have money to pay for their groceries, that market was still booming in. So, you know, irrespective of what's happening with our health and what's happening at our house, everyone wants to look good and best as possible, and they are happy to spend for it. Apart from that, it's a dermal filler, which is just like a gel made up of hyaluronic acid. Other procedures we commonly do is thread lifts, which is by use of a thread to pull the skin up, usually very popular for a lower face, but can be done for a brow. Then we got a face dissolving injections, and Clavella is a very popular one. It is approved for a submental fat. Some people have double chin, and injecting by that area, you can reduce the fat over there and get rid of the double chin. Then you got a skin rejuvenation procedures. They are energy-based devices, as we know, the lasers, the IPLs, and then you got a very old-fashioned way of skin rejuvenation, which is basically taking the top part of the skin away and let the skin regrow, which will have less wrinkles, less pigmentations, and less skin problems. So chemical peel is another way. Then you got microdermabrasion, which is basically, I call a vacuum cleaner of the skin, which get rid of all the dirt, which are hidden in the pores. And the dermabrasion, which is physically shaving off the skin. And then you got some PRP, which is after doing the venipuncture, the blood is centrifuged and all the goodies like the platelets and other factors, they are injected back in someone's skin, which apparently can give a bit of a shine to the skin and rejuvenate the skin. The evidence is a bit lacking here, but there is a huge demand for that procedure. The other name of that procedure, the PRP, is called vampire injections. So as we go through the facial aging, as you can see how things are in 20s, as we get older and older, I think we are somewhere, all of us are somewhere in the middle there in 40s. And so it's not too bad from how we were used to be in 20s and 30s, but we can see how our future is going to be. So in 50s and 60s, if he's still alive, what happens that not only the skin start getting some wrinkles, plus we start losing our volume, and that volume loss is at all levels. So it's not only the skin gets thinner, wrinkly, yes, and then pigmented as well, but along with it, the muscles also get thinned out, and the ligaments get really loose, and even the bone gets resorbed as well. So we have a bone resorption, and that's why you see that the old person has a very small face, because the skull actually resorb under the skin along with the soft tissues. So anti-wrinkle injections, as we have discussed, it's inhibit the muscle, it's inhibit the transmission of neuromuscular junction there, which means that despite of our brain saying to the muscle to contract, because that neuromuscular junction is blocked, the muscle doesn't contract. And if that doesn't happen, that means that muscle doesn't do the etching on the skin, which forms the wrinkles, and that's how the wrinkles disappear. So the anti-wrinkle function of that Botox is actually due to the muscle getting paralyzed, not necessarily the wrinkle disappearing directly itself. It's a bit of a science behind the whole game. And these are the products we have said. The DGA is the authority which governs the medicines in Australia. So these 3 products have been approved. There are some other forms of it, very popular in Asian market, but it's not been approved in Australia yet, and I guess not in UK or in any of the Western countries. There's one thing called Chinese Botox, and it's very cheap, and it's many times we've found that the people are trying to import it illegally and getting caught. The good thing about Dysport, the product we use quite a bit in our clinic, that it kicks in within 3 days. That is much better than Botox, which can take 1 to 2 weeks. And the results last around 3 to 4 months. So it is the good concept about this anti-wrinkle injection or Botox treatment is for our business that people need to keep coming to us. It's just like very much like a hairdresser thing that after every period of time, that person has to turn back to the practitioner. So if you have developed a good rapport and developed a good relationship with your patient, then every 3 to 4 months they come back to us and get the treatment done. So it is a very good baseline income for a practice. I call it as a bread and butter for us. So even if the surgical practice, which goes up and down depending on the season, is not doing well, the Botox treatments actually help us to keep us paying the bills. That is some of the pictures which I got it from the distributor. That's what the effect is. As you can see, that the person on the left are frowning, and even the person on the right are trying to frown, but you can see the difference because the muscles are paralyzed. You can see the effect of it. Things look smooth and the person looks calm and relaxed. Then you got Dermal Filler. Dermal Filler are made up of different sort of products. The most common one is called hyaluronic acid. The hyaluronic acid is actually something which is present in our skin naturally, and that's the beauty about this product, is that because of it is something which is natural in our skin, the risk of allergy is quite low, and that's why it can be safely injected under the skin. It is used for many things. That's how the gel looks like. These are the brands. Restylane is the brand we commonly use, but the other popular brands called Juvederm and Radius is also another brand for fillers. They all come different forms. Some fillers are thin and they can be injected a bit more superficial. Some fillers are a bit thicker, and the thickest one get injected quite deep, and they are to enhance the cheeks on the chin, to make the cheeks and the chin a little bit more voluminous and enhanced. This is some of the results for a lip filler. Once the lips get injected, as you can see, that's the lip looks a bit voluminous, and as well as there is a borderline there. How things are, I guess, when you guys in UK, you have seen lots of big lips on the street, is that right? And it's getting very popular now. Everyone, it's getting to that extent that people don't know where to stop, and they keep on injecting it and getting injected by the practitioner. And because there is a monetary benefit for the practitioners, they don't tell the patient not to inject any further, and is one of the reasons why you see some of the crazy faces on the streets and sometimes in the media as well. But the effect of the filler can be quite good and very natural as well. It depends on how much of the product you're going to inject. So as you can see here, the difference is good, but the person still looks quite natural. This lady had under the eyes filler and the filler at the labiomental fold, which is the fold which forms between the corner of the mouth to the chin. It's also called Marinette lines. Now let's talk about the cosmetic surgery. The cosmetic surgery actually is divided into 3 parts depending on which part of the body it's operating on. So you got a facial surgery, you got breast surgery, and you got body surgery. My work is basically more on facial surgery. I do a lot of eyelid surgeries, plus I do a lot of liposuction, although I do tummy tucks, facelifts, and some breast cases as well. So that's what everybody wants. Nowadays, the things have changed. At one point, smaller bum and bigger breast used to be the fashion, but now it's bigger bum and bigger breast together. That's how it's commonly done, and especially the Jennifer Lopez and Serena Williams and Kim Kardashians. They are the one who are bringing that fashion in. So that's what's popular nowadays here. In a facial surgery, you have brow lift, you have eyelid surgery, you have face and neck lift, rhinoplasty, although I don't do it, considering the complexity of the patient's requirement. I've got trained for it, but I never took it because nose being in the middle of the face, people's expectation is quite high. Then you got implants like cheek and chin implants. You want autologous fat grafting, so getting the fat out of the belly or someone else and then injecting on the face or buttocks. Hair transplant is another specialty on its own. So these are some of my facelift results. Some of my patients who I did a facelift a while ago. These are some of my breast augmentation results if you are interested. This is the lady I did a breast augmentation plus lift together. Body surgery, that's liposuction, tummy tucks, buttock lift, genital surgery. I don't do that, but like penile lengthening procedures or labioplasties. Then you got arm lift, thigh lifts, body lift, and then pectoral implants. Some of the movie stars, you see that how they all got that beautiful chest, and some of that is because of the plastic surgery. The combination of implants plus liposuction can give you instantly a very good pectoralis major muscles, and similarly the liposuction can give you 6 packs very quickly, so you don't have to go and work hard in the gym. I was thinking of telling Abdul Wahid that he's working too hard. You just need to consult one of the cosmetic surgeons. But anyway, so this is some of my liposuction results. So these are my patients. That's an arm liposuction. Even it's popular among hippos. Now, this is the tummy tuck. So those women who have had multiple pregnancies and their skin doesn't go back to normal, or what happened in this condition, in this lady, is that she lost a lot of weight. She lost half of her weight. So Some of them are doing with diet and exercise, and some of them are getting a gastric sleeve procedure, like a bariatric procedure. There is a bit of trend. Australia was at one point was the fattest nation in the world, and people did realize that, and it actually we surpassed US in terms of weight. And then at one point people start realizing it, and the media also helped it and making people aware that the risk of being obese. And there was quite a few TV programs ran simultaneously. One of them was a very popular one called The Biggest Loser, and that was like a reality TV show where people were losing a lot of weight, and some of them were like over 200 and even over 300 kgs, who started losing a lot of weight and eventually get into a normal BMI. So, and because of that, it got influenced on the general public, and people start getting into diet and exercise. And then we started seeing quite a few patients like this lady with lots and lots of skin, and they need a tummy tuck. This is another tummy tuck. This lady had an arm lift with me. There's extra skin at the arms. This is a thigh lift to pull up the skin, lose the skin at the medial thigh. She had a liposuction done along with it. Sometimes people get too much over the board, and then we don't know where to stop. They want a procedure done, every procedure under the sky, and that's where the problem is. And that's, as a part of a cosmetic surgeon, it's our responsibility to let them know that where it's going to work and where it's not. And unfortunately, we see a lot of people with body dysmorphic syndrome. They have a very poor image of their body, and they try to satisfy themselves. They keep on getting the cosmetic surgery procedures, and things get worse and worse. So this is one of the things we have to tackle all the time in our clinic. And if we feel like this person is suffering from body dysmorphic syndrome, then very softly we ask them to go and see a psychiatrist and get it assessed. And I'll just quickly, this is a video of my clinic, so I'll just quickly play it if you guys can see.
Mansoor,
Why it's not playing?
Mansoor, if you slideshow it, then that's the only way you can run this video.
Okay, you can't play the videos?
No, you can play the video, but you need to slideshow it so the video can play.
Yes, slideshow it and see. Or come out of it and see.
No, just let me put it on. So slideshow.
Naseem, can you help there?
I think when he clicks, he's just clicking the image. Yeah, it should work now actually.
Sometimes actually it's easy if you come out of the slideshow, go into the presentation, and then click on it, as if you're preparing or writing the presentation.
Yeah, that's what it is.
It's okay. We can do it towards the end if it's not working. I mean, are you almost towards the end of your slide?
Basically, that's I can play it on the YouTube. It's not a big deal.
Yeah. Okay. Or you can send us a link, and we can actually share it with everyone.
Can you still see my screen?
Yeah,
no.
Yes.
Dude, I can't see the video on YouTube.
Yeah, same here. I can't see the video.
see the video there?
Yeah, we can see now.
That's it. That's it. Thank you.
Practice manager here at My Cosmetic Clinic.
My name is Dr. Masood Ansari and I'm a cosmetic therapist at My Cosmetic.
We offer a wide range of non-surgical and surgical options here at My Cosmetic Clinic, from dermal fillers and anti-wrinkle injections through to liposuction, abdominoplasty, blepharoplasty, breast lift and augmentation, just to name a few.
Our objective is to get the best results for the patient, and we achieve this by listening to the patient, analyzing the patient's needs, and finding the best combination of artistry, medical knowledge, and surgical skills to achieve it.
We treat each patient as an individual, so when you come to see us, you're assessed and your desired outcomes are discussed with you.
All of our team members are presentable, professional, approachable, and knowledgeable.
Our nurses are medically trained, but they're also warm, friendly ladies who genuinely have an interest in making sure our patients walk away happy and confident with their new look.
By having the right team in place, we can ensure our patients will have the best possible experience.
Dr. Ansari is very approachable and grounded, so he makes the process really easy.
It is personally satisfying to see not only the patient's physical transformation, but also a huge boost in their self-confidence.
My Cosmetic Clinic is a place where you will find medically trained professionals who genuinely care about you and your outcomes and the end result that you're looking for.
If you're looking for a great experience by a professional team to achieve your best cosmetic outcome, contact My Cosmetic Clinic for consultation.
If you would like to make an appointment, simply head to our website, mycosmeticclinic.net, and click on the Book Now tab. You'll be walked step by step through the process, and at the end, you'll receive an email confirmation of your appointment date and time, so you can pop it in your diary.
Well done.
And
Nice commercial and marketing.
Thank you, Masood. Thank you very much. Excellent. Excellent talk. Excellent talk. Very enlightening. We learned a lot, really.
Yeah, very enlightening. Thank you.
In the end. So, our next speaker is Dr. Ali Faisal Salim, consultant in pediatric infectious diseases at Liverpool University Hospital. And he's going to be speaking about polio eradication programs in Pakistan and where we're up to, and maybe share some of the research findings. So over to you, Ali.
Yeah, I can't hear him.
Ali, we can't hear you. Unmute yourself. Can't hear you, Ali.
Yeah.
Yeah,
Can you
okay.
hear me now?
Yes, we can hear you now.
Yeah, thank you, Mansoor, and thank you, Naseem, to give me this opportunity to share my work. I work as a pediatric infectious diseases, and I have done my master's in clinical research. I do a lot of clinical research. I'm going to present my polio work today. That's all the real data I have been doing for the last 5 or 7 years since I'm faculty here. So my topic is all the polio studies which I have done, and the data which I spooled up to help in polio eradication in Pakistan and globally. So I have no conflict of interest and no financial benefits from any of the funding agency. What I'm going to present is all these my polio studies include 4 clinical trials and innovation studies which we have done. And lastly, the study which is still going on. So what I'm going to go through is I'll just go through all these studies. I'm going to give you a rationale and one biggest result which we achieved from that study and what actually it impacts nationally and globally. So this is my first study, which is actually immunogenicity of poliovirus vaccine in chronically malnourished Pakistani children. This is the first study which we have done during my fellowship. I just learned that there is some relationship between malnutrition and infectious diseases, particularly in Pakistan. I just pulled up the data and identified, and you can see in this map, these are actually some zones like yellow zones and red zones. These are actually districts of the Pakistan, which has malnutrition status. So the darker you are, the more malnourished, chronically malnourished infants you have. And the black dots are actually the polio cases reported in these areas. And you can see that the darker you are, the more scattered these polio cases, poliovirus cases are there. It means that there is probably some relationship of these, although there is a relationship of this area, this corridor between Pakistan and Afghanistan border, but you can see across the Sindh and across this Balochistan, there are a lot of cases and cases in this. On the other hand, in this map, in this table, you can see that there are a lot of children who receive polio vaccines, like number of doses received among the cases, and you can see a lot of children actually received this polio vaccine. Even then, they got this polio disease. So it means that there is something else which we are missing in the list. I assume that there may be some relationship between malnutrition and poliomyelitis or infectious diseases per se in Pakistan. In the lower bar, you can see the stunting trends in Pakistan, and you can see that the younger than 5 years of age, the stunting is so high in Pakistan. So everybody is actually short as compared to what it's supposed to be. So what we have done, I did a randomized control trial among children who are actually received their oral polio vaccine according to their age as a routine immunization. And I divide them into two groups. One group actually someone who is a chronically malnourished, which is height for weight for height Z score -3 SD. And I check what is the baseline seroprevalence for poliovirus vaccine. So red is actually the malnourished population who is chronically malnourished, weight for high Z score -3 standard deviation. And the green one is actually the normally nourished population. And you can clearly see in this first graph, which is the baseline seroprevalence graph, that the malnourished children has low serum poliovirus immunity compared to the green children, which are actually normal children. So you can see the poliovirus 1, which is the most lethal for us, wild poliovirus 1. The malnourished infants receive polio vaccine, even then they are not converting their immunity into the normal system. At that point in time, actually, I think that intervention should be giving them injectable polio vaccine and see what is the response of the injectable polio vaccine in these children. So that was my intervention. So you can see the intervention mentioned in the below one. So intervention is someone who received bivalent oral polio vaccine along with bivalent polio vaccine and IPV. And you can see that both groups with 4 arms receive this intervention. And you can see this red marks, which is actually red arrow. You can see that red arrow children receive IPV along with bivalent oral polio vaccine. And it's clearly seen that malnourished or the normally nourished, after receiving the injectable polio vaccine, the immunity mount like anything as compared to the malnourished children who received the bivalent oral polio vaccine. At that point of time, the intervention gives the best answer that if you really wanted to eradicate Pakistan, polio from the Pakistan or the globally, you have to add IPV in the routine immunization. So the message was really taken by the international community, and then I present this into the World Health World Health Organization Global Polio Eradication Initiative Program. And you can see this intervention. We start this intervention. They received it very well. They give the recommendation that routine immunization, along with not only routine immunization but also in campaign setting, just use the bivalent oral, this is the IPV, give the injectable polio, inactivated polio vaccine. And you can see that just after introduction of this IPV into the routine immunization, the cases has remarkably gone down in Pakistan. And we published this study in the vaccine journal. At the same point of time when we were just doing that study, the second point come into be that they're going to be a polio endgame strategy, which is actually come out from the World Health Organization. And the plan is actually gradually remove this trivalent oral polio vaccine to bivalent oral polio vaccine, which has poliovirus 1 and 3. Remove the PV2 because PV2 cases has been gone from the international community. And the second is inject 1 dose of IPV should be routine immunization should be given. At that time, we were using trivalent oral polio vaccine. The concern was if there is a poliovirus 2 outbreak and there is no oral polio vaccine, what could be the reason and how we can just cope up with this, massive outbreak of poliovirus 2. At that point of time, I just identify this as a hypothetical problem, and we proposed to the World Health Organization that we should have a study which have 5 proposed routine immunization program for Pakistan. And you can see these are the arms. Arm A is the one which is actually a lot of developed countries receive this IPV, inactivated polio vaccine across. So one arm could be future possibility that Pakistani children should receive just IPV. Other possibility is that you can just receive bivalent oral polio vaccine and no trio V and no IPV. The third possibility is just continue IB or PV and not IP, and along with that you just also receive inactivated polio vaccine. And arm D is actually just to help the arm C if there is an outbreak situation, so we can use this 22 weeks. You can see this, we can use this monovalent oral polio vaccine 2 and monovalent inactivated polio vaccine 2. And arm E at that time was TOPV. At that time when we suggested this study, the arm E was the Pakistan routine immunization. And right now you can see the arm C is actually Pakistan routine immunization. So actually they agree to that. The study results showed that anytime you use just inactivated polio vaccine, your children will have less poliovirus immunity, because maternal antibodies actually interact with the children's antibody and they lead to children more I would say more for the disease. And anytime you include IPV into the arms, you can see that it has more immunity compared to anybody in the world. Arm E was a routine immunization arm, and you can see their immunity was low compared to the arms who have IPV. The results showed that bivalent oral polio vaccine along with one injection will be the main arm which help Pakistan children protected from this polio virus. And if there is a poliovirus 2 outbreak in across the world or anywhere in the world, the strategy should be along with the oral polio vaccine, one injectable polio vaccine. And that is the most satisfied strategy which the study has proposed. The study is well taken, and it gives us a policy implication. And you can see that after some time, this IPV along with bivalent oral polio, which we proposed, was the arm which Pakistani government has took up, and now it's actually routine immunization arm for the Pakistani children across the world. And after this study, there were a lot of outbreaks happen across the globe. So you can see there are a lot of poliovirus 2 outbreak, and at that time the strategy was best utilized by global community and giving this IPV along with the oral polio vaccine. One of the study also has a monovalent oral polio vaccine too. And you can see in the Nigeria, DRC, and Niger, the people use this MOPV2, and the outbreak has just completely shut off. We published a couple of papers out of this study. As we move to the inactivated polio vaccine, there is a concern that the manufacturer is unable to produce this amount of inactivated polio vaccine, which is the need of the global world. So we propose that why should we just use the fractional dose compared to the full dose of inactivated polio vaccine? The fractional dose is actually 1/5 of the full dose of inactivated polio vaccine. There are certain devices which we can use. One is the BCG device, which is actually the 0.1 ml intradermal vaccine device we can use to inject the children. The other are there are a lot of few automated devices which are already been approved by World Health Organization. So you can see some of them are there. So this one, which is actually on the top of it, is Star Syringe device. The lower down, which is blue a background, is a Helm Pharma device. And the last one, which is actually a needle-free injector, which is a Tropis device. So we checked this, that if we use this fractional dose IPV, why don't we use this using these automated devices and see will they produce some immunity or not, one. Number two, how the community vaccinator feels about them. And lastly, is this the one who actually help us for the type 2 outbreak situation? So you can see that using these devices in terms of randomized controlled trial, we were able to produce good amount of results. And the result shows that if we use one of the automated devices compared to the other automated devices, one is better than the other for certain seroconversion of the poliovirus immunity. Not only this, but also there are children who were seronegative in the past, but after giving this fractional dose of IPV, actually they convert into the to seropositive. So the devices, or the 1/5 or the fifth fractional dose of IPV using these devices is helpful. Not only helpful, but give the immunity to the children of someone who is 1 year or more. We also use this in a campaign setting, the needle-free device, and you can see that that needle-free device, which is actually has no needle, and all the vaccine go just by air pressure, 1/5 dose. In this community setting, they also shows that the first giving the vaccine to the first child in the community may take 68 seconds, but as you go more and more children, that the time is actually goes down, and you can reduce down the time to 38 seconds per child for vaccinate this in a community. This is also being taken up after this. We published this, both of these studies into the journal. There was a come out from the as a polio implication, which shows that in an outbreak response situation, we can use a fractional dose of IPV, which is actually helpful. The studies published across by India and Pakistan. Now, the Bangladesh is using the fractional dose of IPV in their routine immunization. Pakistan is also thinking about it. The Sri Lanka is doing, the India is also doing this because of this IPV shortage. We also checked that if we are using this fractional dose of IPV in a routine immunization setting, how long the immunity lasts, because this is 1/5 of dose, not the full dose. So will the immunity last for longer period of time? So what we have done is we just divide a randomized control study to check this question. The question is that, one, we give this fractional dose of IPV at 14 weeks at 14 weeks compared to the full dose at 14 weeks, and then we just follow these children for a longer period of time and giving them fractional dose of IPV and full dose of IPV at 9 months of age, and see how long this fractional dose of IPV lasts compared to the full dose of IPV. That was a recommendation given by this strategic advisory group of the immunization strategy. We should know if, because nobody knows about how long this immunity after giving 2 doses of IPV. The study is still going on. We are almost collected the 75% of the data, and we are just about to end this study in this coming June. However, there are a lot of policy implications on this, and this is a very high quality study which everybody look into globally.
Ali, you have 1 minute left.
All right. So lastly, I'm just going to talk about this. Some children who are immunodeficient and they have this poliovirus, continue to have a poliovirus exclusion. So we last a study to check if there is a children who are immunodeficient and continue to poliovirus exclusion. And we just wanted to develop a surveillance system across the Pakistan and see how we just go into this. So this is one of the study which I'm still going on. And last study which I going to like to that is this: in a high risk population, what is this older children poliovirus immunity, and we are working on it. I will stop here, and I may answer the question at the end if there is any. These are my qualifications. Thank you.
Thank you very much, Ali. Excellent talk. Really very good. Lot of data there, and years and years of hard work, really. So I'm going to open the floor for any questions anyone has. So any questions?
Yes, for Ali. Ali, you mentioned the air pressure induced polio vaccine. So have we actually did a trial on those in Pakistan, or we just know that these things exist?
Sohail, we have done the trial. Almost 900 children were vaccinated with this. We checked their serum immunity after that, and we just found that they are not completely 100% zero immune response, but we expect that their response will be 60% or so, and actually they responded the same pace. So it's not a full dose, so we really don't know if the immunity lasts for longer. That's why we are doing another study to check if the immunity lasts longer and how long the immunity lasts after giving certain vaccines. So we have done this study, and that's what.
So awesome. So based on that trial, I know you guys are still in the process of finding out how long the immunity lasts, but do you think there might be like, if we give one dose now, one dose in 6 months time, maybe they get the full dose and then we don't have to chase up immunity?
So in that study, there are 4 arms. So one arm actually received full dose at 14 weeks, and another child received the fractional dose at 9 months. And we're going to see if there is a full dose versus with fractional dose, or it's just 2 full doses or 2 fractional doses. So we really don't know the answer. We are expecting the answer will come in June, and then see if this is the best way to do that.
Awesome.
I've got a question, Naseem, for Masood. Masood and Faisal, thank you very much. It was an excellent presentation by both of you, and much insight into your practices and into your work. Masood, a question for you. You know, medical negligence and medical litigation is quite high, quite rife actually in the places like US and Australia. I think more so in these places than the NHS. First of all, the first part of the question is, how do you kind of actually deal or how do you kind of explain all that to the patient in order to sort of avoid such huge claims about medical litigations and negligence? And number 2, how do you kind of actually sort of deal with difficult patients who come to you every now and then saying, no, I think this is not what I've asked you to do. You've done something wrong. You've not done what I've actually asked you to do. So 2 parts of the question, maybe difficult to answer as well.
Look, that's a very good question, Naseem, and sorry, Mansoor. The fact is, yes, we come across this. Patients' expectations are pretty high. So what, as a surgeon, what we need to do here is, first of all, bring the expectations down. We need to be very clear about what can be done and what can't be done. There is no point of promising the whole world. You know, it is very tempting. You can convert the patient quite easily by saying that, you know, I'm going to sort everything out for you. But the fact is, if you don't give them a realistic information, then you can be in trouble. So that's one thing. The patients remember that what you're saying. Number 2 is, you know, in terms of complication, what we say is that if you provide that information before the procedure at the time of consultation, then it is an information. And if you provide it after the procedure done and patient come and complain, that's an excuse. So that's the difference between the 2. So you need to be, at the time of consultation, you have to be very careful about it. Number 2 is that those doctors who get less medical legal issues are not necessarily those who are senior most or the most experienced or more technically robust. The people who get less medical legal issues are actually those who build a very good relationship with their patients and make them feel like that they are a part of team. So you just need to pretend yourself that, look, this is a team, this is a patient doctor team, and if you ever have any problems, any complication, we say, look, this is something which has happened, and obviously it's not exactly in your hand or in our hand. These things could happen, and how we are going to sort it out. So you need to stay very much in contact with the patient. The biggest problem for us is that when you get the complication, it's a natural tendency of a surgeon is to run away from it. So, you know, you feel like, you know, I shouldn't be seeing this person, I should avoid it, or I should be, you know, telling the practice managers as to, look, I'm busy or this is so. But if you do that, then you are in trouble. The best thing is just become all ear, let them come and decompress themselves, let them talk to you, and sometimes good to see them more often. Just keep seeing them regularly. And when you do that, then they feel like you are concerned, you care for them, and mostly, you know, you can help them sort it out. So that's
and you develop a rapport as well. You develop a rapport.
Sorry, what was that?
I said you develop a rapport, actually. Even if you see them more often, you develop a rapport.
Exactly. You develop a rapport and then make them feel, and then bring them and keep listening to them, keep talking to them, keep explaining to them. And if you keep doing that, eventually they get on your side, rather than if you try to run away, if you try to hide, you try to avoid them, then the things get really problematic. And that's where the medical legal issues, we all see it on and off. But luckily I haven't had any case which has gone to the court yet. You know, so I was very lucky in that sense. But I have seen with my colleagues, things can got really tricky sometimes.
Thank you very much for that.
I have just two very quick questions. I was making notes, one for Ali and one for Masood. Ali, we read about this herd immunity thing when we were studying. And as far as I remember, I think the concept is if a certain proportion of people get a disease like polio, then the others are protected because of herd immunity. So why has herd immunity not like kicked in, or is it being taken into consideration? How does that concept work? And Masood, question for you is this tummy tuck procedure. So once they have lost a lot of weight and you have removed their skin and everything, what if they become fat and put on weight again? Their skin tears apart, or what happens? So these are my two questions.
Ali Faisal first, yeah.
Protection is if you vaccinate 10 children from the community, the 11th child should be safe from the other children, just because that the virus or the bacteria do not transfer from one person to another. It just die out. So that is the protection. That is the reason behind it. For measles, the herd protection, if you vaccinate out of 100 children, you need to vaccinate 95 children, so that then the 5 children can be protected. For the H influenza, it is just 60%, that you need to vaccinate 60% of the community, 40% just safe from that. So the bacteria does not travel across. For the polio virus, it's highly infectious. It's the oral route or gastric route. It just transports from one person to another. So you need to vaccinate almost everybody in the community, maybe 95% or so. The problem here in Pakistan that our routine immunization is 65% at maximum you can achieve.
Right.
And the supplementary immunization is just completely doesn't work. So for polio, I would say we are not at that stage where we say, okay, the herd protection is there. The problem is that we are not routine cover all these years.
I see. Thank you.
Can I, sorry, Masood needs to answer first, yeah.
Masood. Go ahead, Masood, with the answer. Naseem's question.
Masood, yeah, my tummy tuck question. What if they put on weight again? What happens to their skin that you have removed?
You know, as we have read, remember as a medical student, that the skin is the biggest organ in our body. And it's the most stretchable organ as well. So if they are put on weight, for example, then usually when they put on weight, it's the fat which you are accumulating. And when the fat gets accumulated, the skin also stretches. It's just something which we have seen in pregnant women. The skin is a very stretchable organ. And if they put on weight, the skin stretches. And if the skin quality is good, and that depends on the genetics as well, the skin can contract back as well. And that's what we see quite often, you know, in the celebrities. They have a big baby, you know, big tummies there. And then a few months later, you see that and they got this belly button ring there, and then they're showing off their belly. So their skin is a very stretchable organ. So yes, but saying that, if somebody has extra skin problem and they lost weight and they got a lot of skin and you trim it, then they put on weight, and it means the skin will stretch. But because they have that skin type, which is not going to contract, which in the past it didn't contract, so it's most likely it's not going to contract again. So yes, there is a chance that you might have to do it again, but that also shows that that person is not serious about it. Because if someone is putting on weight again and again, then it may not be a right candidate to do this operation. It's quite an extensive, big operation, and it takes a lot of recovery as well. So it's a high risk patient. So that's, if somebody has put on weight again and come back to me for a second tummy tuck procedure, I would try to run away from there.
Thank you.
Maz, you were asking a question, Maz. Go ahead.
Yeah, I've question, Masood. And first of all, Faisal, really very well presented. You know, you've been working really hard, and I think excellent work. I think you are one of the person I think who's been into research and teaching, and this reflects on your presentation. Really well done. Masood, your presentation, loved it. I've got a question for you because I'm also a dermatologist. So what sort of, because I see those patients as well at times, you know, but I'm not a cosmetic one. But my question to you is about what proportion of patients you see in your, you know, in your sort of practice where you feel that they need, you know, psychoderm opinion or psychiatrist opinion, as you mentioned, you know, and how do you deal with those patients in specific? Do you yourself have got somebody who counsel them, or you just signpost them?
Look, it is a very tricky topic, Mas. Thanks for bringing this up. Look, sometimes I feel like the prevalence is 100%. Every one of us have some mental health problem somewhere hidden. So, but saying that it is a high number, you just need to dig a little bit deep. Some you can do the procedure and make them satisfied, but some they are very hard to satisfy. So saying that, I remember that I saw a nurse. She was 45 kg. So her probably BMI was like 18 and 19. And she came to me for a liposuction procedure. And she said, look, can you do it for me? And I said, what you're here for? And she's liposuction. I said, where's the fat? And she said, oh, look at it, it's fat everywhere. I'm like, this is something which I can't see at all. I'm like, and she was a nurse. She was a registered nurse. So it's not that it's a problem like with education, or it could be a doctor who can have this body image problem. So it's a hard one when you're running a private practice and you may not have that sort of connection. The best thing what I do is to explain to them that, look, you need to go and see your GP. You have this problem, and it's better that you keep the GPs in the middle of this, because they are the one who is going to communicate with the different specialists. Sometimes I write the letter to the GP and say, this so-and-so person has come to me, and this is my feeling is, and I got a feeling that and the problem is that they do a doctor shopping. You refuse, you turn them back, and they will go to somewhere else. And because there is a monetary benefit of it, then there will be someone who will do it. So that's the another thing which I do. I tell them, look, you're not suitable for it, and please don't go to another doctor, because there will be a cowboy somewhere who is will happy to do it to grab your money. And some of them appreciate this advice and some don't. And they will go and find someone who will satisfy them and by doing the procedure. So that is a very tricky situation. I advise them and I go to the GP, but I don't refer them directly to the psychiatrist, because like any other mental health problem, not necessarily they will have an insight that they got this problem. They think they are fine. It's everyone else who is wrong.
And I think it's also important to have patients' consent before you refer them to a psychology or psychiatry service. You cannot just do that behind the patient's back. So it's really important to know that. One question actually for Ali Faisal Salim. Ali, you know that Nigeria, Afghanistan, and Pakistan are amongst the 3 countries where polio is still endemic, actually. You talked about your vision, you talked about Pakistan's vision. When do you think Pakistan is going to be eradicated from polio?
It's $1 million question. Nobody knows it. Nobody knows it. I was just a couple of weeks before I was in Geneva at WHO presenting this IBTPV work.
This is why I asked you the question, because you were with the biggies.
Yeah, so like they asked me the same question, and there is no answer for it, because the last year we had 12 cases. This year we already had 8 cases, and we are just entering into the best season. So it's a tough question. The problem here is different. The problem is not people. The problem is the people who are running the show. The problem is beyond it. It's as Masood said, monetary thing. It's all about monetary thing. So there are people who are actually not vaccinating the right children, right spots. That is the reason. It's not religious. It's not political. It's beyond it.
Okay.
I have a question for, thank you very much, Masood and Ali, for a wonderful presentation and the work you have presented. I have a question for Masood regarding the Botox injection for wrinkles. And you said that it get paralyzed the muscles. So how it affect the expressions when somebody is in anger or somebody is like happy?
Good, great question. What a good question.
So, to Masood.
Thank you. Very good question.
It's good to see you after a while. Now, look, the muscle paralysis is not all and none. It is actually depends on the dose. Higher dose you go, then more paralyzed the muscle can get. So look, there are some muscles which you want to move, and some that even if get fully paralyzed, it's not a big deal. Like the muscle of a frown. So when you frown, that is not a very good expression. Like I'm frowning at the moment. If you look at me, you feel like I'm stressed, I'm unhappy, or something like that. That is an expression. If you completely freeze, it's not necessarily a bad problem to have. People are very happy if they can't frown, especially at work or at home. If the wives won't frown at the husband or husband won't frown at the wife, then I think life will be much happier. Do you want me to frown for you, Mansoor, if you're taking a picture?
Yes, thank you. Thank you.
You're frowning as well while you're taking a picture, so you need to come to me. I will fix it for you.
Yeah.
So,
Let's go to Masood to get some faces.
So much with these goras, where we don't, it took me many years to realize when they are happy and when they are upset. And now you're telling me with these expressions as well, we will find it even more difficult to pick them up then.
Yeah, right. That's and it's obviously the British are not very expressive people, either with or without Botox.
They say we have a stiff upper lip.
Yeah.
Yeah, British people, yes.
They have stiffness in many places, but not the right one.
It's all recorded, guys. It's all recorded.
Not the right one. I'm talking about neck stiffness. Yeah. Guys, it's Ramadan here, so I have to be very careful what I'm saying. So anyway, so we're going back to the same topic. Yes, Hasnain, answer to your question is that yes, if you freeze too much on the forehead muscle, which is a frontalis muscle, then it can freeze. If it completely freezes, these are the same muscle which pulls the brow up. So you can have quite a bit of a brow drooping. So that there are a few muscles. Another muscle which you paralyze, you can be in trouble, is the one in the upper lip. The smoker's line. Sometimes you have seen the lines on the upper lip. That's called a smoker's line. Either you're a smoker or not, you can have those lines. More common in smokers. And if you put too much of product there, then you can be in trouble because this orbicularis oris muscle is a sphincter. So if you paralyze it, then the person can start dribbling, or even in a severe cases can start spitting while talking. So you have to be careful. The dose is the secret. One has to know how much you are injecting, and it's quite dose dependent. I hope I've answered your question.
Very good question. That's fine. Thank you. Which means it's a very side effect.
Any more questions before we conclude?
No, thank you very much. Thank you for both excellent presenters. Thank you. And I've actually sent the certificates to all of you. So here, I just need your email address. Everyone else's certificates should be in the inbox. Thank you.
So excellent talks. I think we conclude our session. We will take a summer break, and I think we are back July, is it, Mansoor?
August. It's August. It's the first Sunday in August.
Okay, so we're back first Sunday in August, and we'll try and accommodate, as Masood suggested in the beginning, to maybe take some US colleagues on board and move the time schedule a little bit forward to accommodate our US colleagues.
And Irish colleagues as well. We've got Hasnain, Ireland.
Yeah, absolutely.
Thank you very much, and Ramadan Mubarak to everyone. Thank you, Faisal. Thank you. Allah Hafiz. Good night. Take care.
Thank you.
Faisal, I got another question for you. I know that's a bit different, and now it's finished, but I got one question. At one point, we heard that the oral polio